Assalamu alaikum everyone. My name is Dr. Hajra Zafar Siddiqui. Um, we will be touching upon this topic of ventilatory graphics today. So I'm pretty sure that all of the clinicians who are involved with care of our patients in the ICU would be well aware of these graphs that we often see on our ventilators. In many a times they are ignored rather. People just look up the readings at the side of these ventilators in order to draw their own conclusion regarding the patient. So today we are likely going to touch upon these graphs and what they mean in the longer run and how can they really change our patient management. So the purpose of this presentation would be the graphs and the waveforms which reflect patient ventilator systems and their interactions. And the monitoring of these graphs will allow us to interpret and evaluate troubleshooting as the patient interacts with the ventilator. We will be able to monitor the patient's disease status, specifically the compliance and the airways resistances, assess patient's response to therapy, monitor ventilator functions, and allowing fine tuning in order to decrease the work of breathing for our patients and making them more comfortable to the ventilatory settings. So the purpose of this presentation would be, we would be going through a lot of pictures and what they mean. So there'd be little text and there'd be a whole lot of graphical representation of things. First and foremost, we would be discussing the waveforms that we get to see on our ventilators. So typically they can be divided into two types. There would be the scalar waveforms and there would be the loops. So scalars are basically waveforms where one of the quantities such as pressure, volume or flow is basically uh, compared with a time variable on the x-axis. And in loops, pressure, volume, and flow are charted against each other, and no time component is involved. So basically, 6 waveforms are seen on the ventilator screens, and they can either be the square waveform or the ascending ramps, the descending ramps, the sinusoidal waves, the exponential rises, and the exponential decays. So for all intents and purposes, if you learn this, this is going to help you a whole lot. So the pressure waveforms in any of the two modes that we most commonly come across, it can be either a pressure mode or it can be a volume mode. So whenever you're looking at a pressure waveform, it would either be a square wave, it would be an exponential rise, or it could be a sinusoidal. No fourth option would be available for a pressure wave. Now, if you come to the volume waveform, it is even easier. You will either see an ascending ramp or you see a sinusoidal wave. For the flow waveforms, you can see any of the following. So the flow waveforms can have 5 types of waveforms. The pressure waveform will have 3 types of waveforms, and the volume waveform will have only 2 types of waveforms. As we discussed, most of you would be familiar with the two most commonly used modes of ventilation. It can either be the volume mode or it can be the pressure mode. So when you look at a wave, for example, you're looking at a pressure wave, it is going to appear differently for a volume mode and it's going to appear differently for a pressure mode. So for a pressure mode, like we discussed, it would be a square wave. And for a volume mode, it would be an ascending ramp. So another trick to remember this is a volume wave showing pressure. In a volume mode, pressure wave would have a peak pressure and it will have a plateau pressure. But a pressure wave in a pressure mode is only going to have a constant pressure because that would be the pressure that is applied by us on the ventilator. Similarly, a flow wave on a volume mode will always be a square wave. And on a pressure mode, it would be a decelerating ramp. So these are two of the most common ways by which people can commit it to their memory. Pressure times scalars. In volume mode, the shape will be an exponential rise on an accelerating ramp for mandatory breaths. In pressure mode, the shape will be rectangular square wave. This means that the pressure remains constant throughout the breathing cycle. And whenever an inspiratory pause is added in the volume mode, it helps in the distribution of the ventilation. Now, what are we actually trying to assess by a pressure time scaler? So we will be able to identify the auto peak of the patient or the airway obstruction. And with the same token, bronchodilatory responses can be looked at. The respiratory mechanics, such as the compliances and the airway resistances, active exhalation, red types, peak inspiratory and plateau pressures, peak asynchrony, and triggering efforts. In a pressure time scaler, the baseline for the pressure waveform increases when peak is added. So this is a value of 0, if you can see over here. And when you add peak to it, it's obviously going to rise from this value of 5. And then it will reach a peak value, which is the peak inspiratory pressure, and then this would be the plateau pressure. And whenever a patient tries to make an effort to breathe themselves, you will see this little dip over here. I hope you can see the pointer on the screen. Yeah. Whenever it is a controlled breath, there would be no dip over here, but whenever the patient tries to breathe on their own, you will observe this dip before the patient starts breathing. So if we are to label this, the area under the curve is always going to be the mean airway pressure. So this part of the curve shows the airway resistances. This shows the alveolar distension pressure. And like we mentioned before, this would be the peak inspiratory pressure and the plateau pressure. By the same token, so we have come across a lot of different diseases which would either lead to an increase in air resistance or decreased compliances. So whenever there is an increase in airway resistance, you will only appreciate an increase in the peak inspiratory pressure, and the plateau pressure is going to remain the same. While in cases where the compliance decreases, both the peak inspiratory pressure and the plateau pressures increase. And this is how one can appreciate these changes or the patient's mechanical ventilatory mechanics on the ventilator. How do you determine whether a patient is having problems of auto PEEP or air trapping? So in a pressure time scaler, while performing an expiratory hold maneuver, the waveform rises above the baseline. For example, in this scenario, it says that the expiratory hold was applied and then the auto PEEP rose to a total value of 9. And then when you deduct it from the amount of set PEEP, you are able to determine the PEEP. Yeah, you are able to determine the total PEEP that can be applied to this patient. So for all intents and purposes, you would want this auto PEEP to be lesser than 5 in order for it not to create hemodynamic changes in a patient. Yeah. And for doing that, you can increase the value of the set. For volume time scalars, the volume waveform will generate a mountain peak appearance at the top. It may also have a plateau or a flattened area at the top of the peak. So, if you apply an inspiratory pause, that is exactly when you're going to get this type of a waveform. Otherwise, you'll be seeing this peaked waveform. What will a volume time scaler tell us? It can tell us about air trapping or auto PEEP. It can tell us about leaks, tidal volumes, active exhalation, and asynchrony in a patient. So the same technique, beginning of inspiration. This is where the inspiration ends and the expiration begins. And then this would be the exhaled volume before it returns to the baseline. Now, how can we determine the air trapping or the leak which is occurring for such patients? So if you have this nice volume time scalar, and the volume wave on the volume time scalar does not return to this baseline over here as it should normally. Over here, you can see that it's returning to the baseline, and over here, you can see that it just abruptly drops. This means that either the patient is losing some volume, there's a leak in the circuit, or the patient is having air trapping for patients such as emphysema or chronic bronchitis. This may be the case. Flow time scalars. In volume modes, the shape of waveform will be rectangular or a square wave. This means that the flow remains constant throughout the breathing cycle, while in the pressure mode, the shape of the waveform will have a decelerating ramp in the flow pattern. So sometimes, okay, I think it will be covered in the slides ahead.
प्रेशर का उसमें वेयर होगा लो टाइम में
नहीं हाँ फ्लो टाइम प्रेशर मोड्स में फ्लो टाइम में डिसेलरेटिंग रैंप होगा दिस थिंग ओवर है और वॉल्यूम मोड्स में स्क्वायर वेव होगा एंड दिस इज वन ऑफ द रीजंस कि आप जब प्रेशर मोड्स में होते हैं तो आप ज्यादा टाइडल डिलीवर कर सकते हैं बेस्ड ऑन दिस डिसेलरेटिंग फ्लो विदाउट एक्चुअली अचीविंग लार्जर पीक प्रेशर्स और जब आप स्क्वायर वेव डिलीवर कर रहे होते हैं तो उसमें आप छोटे टाइडल्स डिलीवर कर पा रहे होते हैं विद कांस्टेंट प्रेशर यस या पीक प्रेशर आपका बढ़ जाता है ऐसे सिनेरियोस में अच्छा थोड़ा सा ना मैडम फिर ना ये बिल्कुल एक डिफरेंट क्लास हो जाएगी क्योंकि वॉल्यूम मोड और प्रेशर मोड्स की फिर वो बहुत उसमें डिटेल है so it can also help us in identifying the air trapping, the airway obstruction, the bronchodilator responses, breath types, flow volume, flow waveform shapes, inspiratory flows, asynchrony, triggering effort of the patient. Yeah. So this is the concept that we are discussing over here, Dr. Zaid. That the decelerating flow pattern may be preferred over the constant flow pattern. The same tidal volume is delivered, but with lower peak pressures. So you can see over here that with the decelerating waveform, you can deliver 516 of tidal volume at a peak of 26, and over here the peak has rose to 29 for delivering the same volume. Now auto peep and air trapping. This is a nice waveform of the flow pattern. And if this flow pattern does not reach the baseline, for instance, in this case, then we are very sure that either the patient is trapping air because of any of their conditions. So if the expiratory flow does not return to the baseline, then we are very well aware of the fact that this is air trapping. And in a ventilatory waveform, it would be something like this, that this thing is not touching the baseline, which is over here. Similarly, you can also appreciate the bronchodilatory response. So this is a patient, let's say an asthmatic, pre-bronchodilator and post-bronchodilator. So pre-bronchodilator, we can see that the E time is longer, that the peak expiratory flow is not as much as we would want for that patient. Post-bronchodilation, you will be able to appreciate a shorter E time or a better E time compared to the previous waveform, and an improved peak expiratory flow. And you will also see that the flow time scalar is returning to the baseline. As previously mentioned, one of the ways to remember the pressure wave in the pressure mode is that pressure waveform will always have a plateau. And a volume wave, in a volume mode, the pressure wave will have a peak and a plateau pressure. Now we'll be discussing some of the loops. For example, the pressure volume loop. volume would be on the y-axis, pressure would be on the x-axis, the inspiratory curve would be upwards, be something like this, and the expiratory curve would be downwards. Positive pressure would always go counterclockwise. The bottom of the loop would be at the set peak. It will be at zero if no peak is set. And if you are to draw an imaginary line down the middle of the loop, the area on the right will represent the inspiratory resistance, and the area to the left is going to represent the expiratory resistance. We will be able to assess the overdistension of lungs, the airway obstruction, bronchodilator responses, respiratory mechanics, work of breathing, leaks, flow starvation, and triggering efforts. So if you are to see over here, this would be the inspiration, this would be the expiration. This is the dynamic compliance. This, whenever inspiratory resistances are going to increase, this part of the loop is going to expand out to the right. And whenever the resistance or the elastic work of breathing is going to increase, then your loop is going to expand out to the left. And sometimes it follows the pattern. The pressure volume loop will follow the pattern of the mode of ventilation that you are using. So the loop is almost square in pressure modes because pressure would be your limiting constant over here. And in cases when pressure continues to rise with little or no change in volume, you would see this bird beak appearance. So in such a case, this can be helped by decreasing the pressure, because we are well aware of the fact that the pressure is rising over here and it's doing very little to add to the additional volume of the tidals. So which means that we are giving too much of a pressure to the patient, and the same amount of volume can be added with lesser pressure. So you can just look at it and go back and make the correction on your ventilatory settings. This is what we discussed, that this is what a normal pressure volume loop would look like. And whenever there would be an increase in the inspiratory resistance, it's going to bulge out to the right. And whenever there is increased expiratory resistances, it's going to bulge out to the left. So increase in expiratory resistances is seen, and inspiratory resistances can also be seen in cases where the tube is kinked or the patient is biting on their tube. Again, one look at the ventilator and you can exactly make out what's going on. So for decreased compliances, you would see this loop coming towards the right. And for decreased compliances, you're going to increased compliances, you're going to see it really upright. So compliance is basically change in volume per change in pressure. So over here, as you can appreciate, a little pressure is going to add a lot of volume to the waveform. And this is seen in cases where the patient is suffering from emphysema, or even after therapy with surfactant, you can appreciate this change in your patients. Similarly, for patients who are having decreased compliances, such as ARDS or congestive heart failure, this is the sort of graph that will be seen. This is classically a graph where the patient is losing their volume somewhere. So it shows a leak in the system, because we know that the inspiratory part of the waveform is intact, but at the expiratory part, there's a leak and it's not returning to its baseline. Flow volume loops. Flow is plotted on the y-axis and volume is on the x-axis. The flow volume loops used for ventilatory graphics are the same as those that are used in pulmonary function testing. Inspiratory is usually above the horizontal line and expiration is below it. The shape of the inspiratory curve will match what's set on the ventilator. So the shape of the expiratory flow curve represents passive exhalation. It's long and more drawn out in patients with less recoil. What can be determined by it? We can see if the patient is trapping air or there is some airway obstruction, airway resistances, bronchodilator responses, increased expiratory flow, uh, flow starvation, leaks, water or secretion accumulation, and asynchrony. Yes. So these are the 2 points that we need to see: where your inspiration is starting, where it's ending. So it is going to start from a predetermined volume, and then it's going to end up at the set volume of tidal that you have determined for the patient. And then once that tidal volume is achieved, it is going to go into expiration, with this being the peak expiratory flow, and then it will return to the baseline tidals.
Especially for the pressure rise over.
Yes.
Different pressure of
And it will also correlate with the type of flow that you are using for your pressure. So the inspiratory limb can either be flattened out like this if you are using a square wave on your flow loops, and it can show a decelerating ramp, as we discussed previously for our flow time scalars. And it's just going to be the very same. If it's not going to return to its initial point of initiation, it means that there is a leak in the system. And depending upon whether the leak is in the inspiratory loop or the expiratory loop, it exactly points out where in the ventilator or the patient you are supposed to look for that leak. So if the inspiratory curve scoops, that means you are dealing with upper airway obstruction, specifically extrathoracic obstructions. Similarly, if your scooping is in the expiratory loop, it means you are dealing with problems such as smaller airway obstructions, such as asthmas and emphysemas. This is a lot of text which basically elaborates on what we have already discussed. Asynchrony. What can be the causes of asynchrony? It can be because of flow starvation. Maybe the ventilatory settings are not adequate enough for the patient. It can be because of neurological injury, and they can be uh, ventilatory settings which are just not meeting the current requirement of the patient. So how would you identify it? You'd be able to identify it in all of the waveforms. The pressure wave is going to show it, the flow volume, the flow wave is going to show it, the loops are going to show it. And how do you go on fixing it? So you will basically want to increase the flow rate, decrease the eye time for the patient, change the mode, sometimes changing from a completely supported mode to from a controlled mode to a partially supported mode, and then a completely supported mode might help solve this problem. And sometimes your patient might need paralytics, but that is not usually the way to go around it. Or you might want to change the sensitivity for the patient. So this is how your waveform is going to look like in a volume controlled mode. Your pressure waveform is going to show this. So it's not a nice uh, accelerating ramp over here. You're going to see this dip over here, which basically shows that the amount of flow volume for the patient is just not enough. And this is how the flow volume would look like for a patient who is in air hunger or is in air asynchrony. So rise time, what is basically the rise time? The inspiratory rise time determines the amount of time it takes to deliver a proper amount of volume to the patient. And it has a lot to do with the airway resistances of the patient and the peak flow rate that we have chosen for our patient. It also helps us in determining if the ventilator is meeting the patient's demand in pressure support mode. So if the rise time is too quick, You might appreciate this wave on a pressure time scaler. And if the rise time is very, very slow, then you would be able to observe this slow rise. You will find this slow accelerating waveform on the pressure time scaler. An inspiratory cycle basically determines when the ventilator cycles from an inspiratory mode into an expiratory mode. And for different ventilators, it has been given different names. But the basic concept is that peak inspiratory flow of a patient is broken down into percentages. And whenever a set percentage of that is reached on the ventilator just goes into the expiratory phase from the inspiratory phase. So, for example, if you set it, let's say, at 75%, then maybe you are able to achieve a very small quantity of tidal volume and the ventilator is going into the expiratory phase. But if you maybe set it at 25%, 30%, then it is able to uh, deliver an adequate amount of tidal to the patient if the patient may be in need of. So if you look at it, if you set it too early at 60% of the peak inspiratory flow, maybe not enough tidal is being delivered. And if you set it at a very lower percentage of the peak inspiratory flow, then maybe you will see this exhalation spike, and it just shows that you're making the breath too long, because of which it would also cause an increase in the workout breathing and would also lead to a rise in this exhalation spike will also be appreciable on the ventilatory mechanics. Would be all.